to Your Health, Your Choice. I am Dr. Roopnarine, and we're coming to you live from our studios at Olera Heights in San Fernando. Today is Wednesday, the 15th of March, 2023, and on tonight's program, we're going to be discussing cancer beyond diagnosis. In the studio with me tonight is Dr. Visham Bhagaloo. Dr. Bhagaloo is a specialist medical officer in clinical oncology. As usual tonight, guys, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So, guys, tonight, it's not an easy topic. It's a difficult topic. We're going to talk about cancer. We're going to talk about the impact after diagnosis. So, guys, please join me in welcoming our very special guest, Dr. Visham Bhagaloo. Doc, welcome to the program. Thank you for coming in. Welcome to Your Health, Your Choice.
Thank you very much for having me, Dr. Roopnarine, and it's my pleasure to be here.
All right. So, Doc, myself and yourself have been communicating a lot within recent months. We've been talking about different patients that we have in the community that we're looking after. And it's not an easy field of medicine. It's not an easy field for someone who is not a specialist in the field like yourself. And it's not easy for the patients and the public out there to really understand cancer and to really understand what services, what options they have beyond, and what happens after the diagnosis. So I'm really glad that you're here tonight to give us some insight and to share your knowledge with the population.
Absolutely.
So, Visham, if you could start with the first question being first. I suppose when someone receives a diagnosis of cancer from their doctor, the immediate initial emotion is one of anxiety and fear. And I suppose the first question they would ask is, doctor, can you fix this?
Yeah.
No matter what cancer it is, the first question someone will ask is the natural question is, doctor, can you fix this? Doctor, can you cure me? How would you answer that question to your patient?
So that's a very complicated question.
Yeah.
But what we do is, and I try to explain to my patients, let's take this in a stepwise approach. Mm-hmm. When you have a diagnosis of cancer, that comes from the fact that we have a biopsy that is telling us that this is in fact a cancer.
Yeah.
So this can be a biopsy of a lesion in the colon, it can be a biopsy of a breast lesion, it can be a biopsy of anything.
Yeah.
So that report will tell us that, hey, this is abnormal cells, they're growing like a cancer, so we have a cancer. The second step is knowing your stage. In every cancer, there's a particular way in which we will stage you. What that simply means is the cancer localized? Has it spread to regional areas, or is it spread to distant organs?
Yes.
That combination of information tells us exactly where we are at and what we can give to our patients. Mm-hmm. Curing our patients has become more and more common because as information continues to be updated, we are curing situations or conditions or stage 4 disease, like we will explain later on. We are able to cure some patients.
Okay.
So it's a stepwise approach,
yes.
And I understand the anxiety, I understand
yes.
the worry,
yes.
but I tell them, let's do it one step at a time, and then from there, I can tell you what stage you are, mm-hmm. what our next approach is going to be, and what our options for treatment are.
All right, so what I take from that is, yes, we can cure this problem. Yes, we can fix you.
Absolutely, absolutely.
Yeah.
But like I said, and I always like my patients to remember that once you tell me, and once I have the full information, I like to give you the full explanation based on it. I think starting or embarking on a conversation with half the information is always going to end us in a slippery slope.
Yeah.
And yes, so for our patients, cure or treatment, I should say, is definitely a possibility.
All right. It seems like, I don't know if it's a perception, but a lot of patients say this to me as well. And Dr. Robin, it seems like a lot of people have cancer nowadays compared to the past. And it seems like every family has someone, a loved one, or a friend who has cancer, who might have passed away from cancer, or is suffering from cancer. How common is cancer in general in Trinidad and Tobago?
Yeah.
Is it more common nowadays than before, or what is happening?
So I think this answer is twofold. So
yes.
Trinidad as a society in itself,
yes.
we are very secretive with certain things.
Yes.
And cancer has always been one of those. It's a very taboo topic. Absolutely.
Yeah.
So a lot of my patients are diagnosed.
Yeah.
They don't tell their relatives. So their immediate family knows. But beyond
That's a
that,
very good point.
it's actually stopped.
Yeah.
So what we have been trying to promote is education.
Yeah.
I think when we get that taboo or that fear from that C word, we're going to get more and more cure. The earlier I can treat you, the more the more likely it is for me to cure you.
Yes.
And I think that's what our population needs to understand, that cancer, once we diagnose you early, once you screen early, that is what we need to do. We need to get you under treatment early.
Right.
So we will talk about this later on, I'm sure. I'm talking about screening for breast cancer, screening for cervical cancer, screening for colon cancer, rectal cancers. Patients sometimes are very hesitant. They're like, doc, I don't want to know. And I was like, I understand, but if I know earlier, I can definitely treat you, I can cure you, and we can move forward from there.
Yeah. So I suppose beyond the taboo, there's a lot of fear still.
Absolutely. I think I would say, like you mentioned earlier in the question you're asking, how common is cancer? And how rampant it is in your private practice as a general practitioner, in the community, it's very common. And it's because of a number of reasons. One, we are detecting more and more cancers because more patients are being screened, but more so when we investigate now, it's more in keeping with you come in, you get a CT scan. And that CT scan is going to pick something up, and then we're going to start chasing it. And now physicians, and we're trying to promote education. So a lot of the GPs are picking up diseases a lot earlier, and that has been the backbone of our society. Like in the UK and the US, the GPs are our gatekeepers. And the more they detect, the easier it becomes for us in secondary and tertiary facilities.
Agreed.
So the last estimate from WHO, we expect for cancer to become as common as 1 in 4 to 1 in 5. And that has to do with a number of things. That has to do with more genetic predispositions. Our population is living longer and longer. And it also has to do with the fact that we're not just taking care of ourselves anymore. Obesity is on the rise, childhood diabetes is on the rise, and there's a lot of information that suggests that these are associated with developing cancers in the future. Stress, we both were talking about stress in our current jobs and stress in general. And that's a big aspect of what has been a central role. Long ago, I tell my patients for head and neck cancers, smoking or esophageal and gastric was smoking and alcohol. Now it's stress. Now it's very, very different.
So you're saying that stress is an independent risk factor for cancer?
So I've seen a lot of talk shows talk about it, and to be honest with you, I always tell myself, I've never seen that written in literature, but what I can tell you is think about our lifestyles, think about the hours that we work, think about the stress, think about our eating patterns. That indirectly causes an unhealthy lifestyle, and I can vouch for that. And that in itself increases my risk of my cortisol is always high.
Diabetes
that correct is right. And then just even in your tummy, in your stomach, when you have this continuous acid production that you're not dealing with because you're not eating, gastric cancer, more so a specific type called adenocarcinoma, and physicians will tell you about Barrett's esophagus, which is a transformation from acid reflux. And acid reflux comes from poor eating habits, which we all have, and then that leads to stress. Correct is right.
Lifestyle diseases.
Absolutely.
And lifestyle in terms of traffic and worried and not eating on time and working extra hours and working longer.
Correct.
So I suppose the answer to a lot of the problem, even in terms of cancer, which is the answer to a lot of chronic conditions that we discussed in this program, is that sort of work-life balance, isn't it?
And that is quite impossible. I can be the first one to vouch for that. It's necessary, but it's quite difficult.
So the topic tonight is cancer beyond diagnosis. So a person receives a diagnosis of cancer, and obviously the first question, can it be cured or not, and they ask you that. What happens next? What sort of support team is available to someone in the public sector, for example, when they have a diagnosis of cancer? I mean, we're not just going to, I suppose you don't just tell them they have cancer and yes, you could cure it and then send them home.
Correct.
I suppose there's a multidisciplinary, there's other professionals, there's a team that comes into play.
Absolutely.
Can you describe that for me, please?
Right. So when an individual comes in with a histological or biopsy-proven cancer, they can be referred to many teams in any of the general hospitals, depending on where the cancer started. So for instance, if you have a female cancer that started in that system, you can be referred to a gynae oncologist. If you're a male or if you have a urological cancer, you can be referred to a urology team. So that team will bring you into our public system. When you are into the system, or even the general surgeons, so they enter you, they will then screen you and they will stage you. So that stage will tell us what is next. And the options, generally speaking, for cancer is it can be surgery, it can be chemotherapy, it can be radiotherapy, it can be immunotherapy. And based on what we find on those information, then we sit together as a group, like you said, a multidisciplinary team, and we make the best plan for the resources that we have in Trinidad, taking into consideration what the international population is doing for this particular condition.
Best practice, international practice.
Correct. So, like I always say, in every institution that I've ever worked in, we aim and we strive for best practice, and not just local best practice, international best practice.
Right. So so when you have let's say you have a few cancer patients coming through the system,
right?
The surgeon would sit with yourself, who's the oncologist, who would sit with other surgeons to make sure that he's making the right decision, and you'll actually meet as a team to discuss these cases.
Correct. So right now it's called a multidisciplinary team. So I'll tell you, for instance, with the surgical teams, we sit in a room. We have a radiologist, we have the general surgeon, we have an oncologist, we have a pathologist.
Right.
So the oncologist is me. We look after treatment, the chemo, the radiation. You have the surgeon. They will remove. You have the pathologist who will give us all the information we need on that sample. And you have the radiologist who will go through everything with us. While we are all individual specialists, we all have an idea of everything. So it's checks and balances. So long ago when you walk into our office and a doctor says, take that out. That's no longer how we operate. It's a meeting. It's a team decision. And like I will always tell people, I may not always agree, but it's not a one-man show. It's a team, and what the team decides is what we do for our patients.
So let's say you have someone has moved on, they've gotten a diagnosis of cancer, the surgeon has done his best in terms of taking out what he may see as a major cancer. What happens next to that patient? And also, who else is part of that team besides the medical doctors you just described there?
And that's a brilliant question. And I think, and I will touch on it. So what happens, and this is the hardest thing to explain to patients. They will come into our team, which is the oncology team, and they'll be told, you may need chemo or radiation. And they'll be like, doc, what are you talking about? The man just take it out. And I'm like, all right, so what you have to look at is we look at certain factors. We look at how big the tumor is. We look at how big the margins are. We look at the grade, a lot of nitty-gritty. And I tell my patients, while the surgeon may have cut that tumor out, the possibility of microscopic disease is based on these factors. And if they are high enough, I will offer additional treatment. So the easiest example is breast cancer. So the surgeon takes out the lump, they do that surgery under the armpit, they tell you, you are cured, go see the oncologist.
And then
they walk in.
Wants to know why, if they are cured.
Absolutely. So they walk into my office and I am telling them, you need chemo, you need radiation, and like, doc, what craziness is going on here?
We just took out the cancer.
Correct, is right. But I think what the audience needs to understand is that how this is about insurance. There are risk factors which increase the possibility of a cancer coming back. And once we can nip that in the bud earlier rather than later, then we're on the right track.
All right. So just give me an idea of the additional allied staff that you have.
Absolutely. So at our institution and at most of the tertiary facilities, we have on board, and we're privileged to have a dietitian, which is essential. Patients are going to have problems, and you're going to have a lot of myths. You're going to have people who tell you stop eating sugar. You're going to have people who tell you stop eating meat. And I think you need to have the appropriate advice from the appropriate professional. I do not speak about diet. I have an opinion. I have some knowledge, but I'm not a dietitian. In addition to that, we have physiotherapy. A lot of common complications women will tell us about is lymphedema.
We see that a lot.
Right? And I think a lot of times the way to prevent or to stop lymphedema is early referral to physiotherapists. So we have that available in the public system. We have speech therapists available in the public system. And we have a social worker who is the most important part of this entire system.
One thing I think that if I could be a little critical of your answer there is about the mental health part of having a diagnosis of cancer and the sort of psychological support. Is that available to patients as well? I didn't hear you mention it.
So what happens is that how my team that I currently work with, we've had lots of sessions with an external regional health authority that has helped us in communication, breaking bad news, and supporting our patients. How the public system works is that the social worker provides that support.
I understand. So they have that training?
Absolutely. So they engage, they start the conversation, and by certain cues, if any of us pick it up, we get further support. Psychologists, psychiatrists, and the full supporting team.
So support is only a phone call away then?
Absolutely. So I have strict rules with my team, and they will all tell you, any patient who comes into my to my service, they must see a social worker.
Right.
Because as much as I can sit and treat that cancer from now until thy kingdom come, I am not the only support that they need. But what I will tell you in the public system, and what I've noticed, is our nurses are amazing at engaging patients on social issues, emotional issues, and they play a central part in taking care of that aspect of the psyche.
Right. And I suppose psychologists are available as well.
Absolutely, absolutely. Psychologists and psychiatrists, and interestingly, in some of the public systems, especially even where I practice, the department is actually next door.
All right. So, I mean, this is a great elucidation of some of these services and what happens in a public sector setting in Trinidad and Tobago, and therefore available to our patients.
Correct.
Right? What if someone chooses to go privately because of the care of cancer and so on, and the surgeon has operated them privately and so on, but as we see in Trinidad, sometimes things are very expensive in the private sector. How easy is it to flow back from those type of patients into the public sector? Sometimes they might be worried, patient might be worried, but doctor, they might not treat me as good, or what can you do to relieve that group of patients that are going, hey, this has become too expensive for me in the private sector. I want to go into the public sector and I want them to treat me well, and I don't want to be discriminated against because I went privately. That's a common thing you hear. It does not mean that it's true, but it's a fear that people may have.
It's absolutely true.
But I know the doctors are fantastic in the public sector as well.
Yeah.
We've been hearing more and more that from patient reports, doctors are fantastic in the public sector. Tell us, and the nurses, tell us how easy is that? Let's speak to those particular group of patients who have that concern.
So what I want them to understand is that whatever you do as an external, meaning be it in a private, public, whatever setting, we are not here to judge. That is not of my business. All I care about is the individual that is in front of me. I don't care if you did 25 chemotherapy sessions, whatever. That has nothing to do with us. Right. You are now my patient. You are now our patient, and we take care of you. Okay. I have made it clear to my team, because you're right, that has been a notion in the past. Any support, any care that was done in the private setting and the patient now comes to public, it helped us to help one additional patient.
Exactly.
So never ever fear. What was done in private, it was done in private. That patient comes to us, we will take care of them like we've taken care of every other patient that steps forth in our door.
All right.
Any patient, and I have a lot of patients who've come to my office, and if you ask any of my patients to meet my private patients, they will tell you I'm the first person to refer somebody to hospital. Because this is about care. As you rightfully said, private oncology care is expensive, and at the end of the day, what matters is treatment. Quickly and properly. What I have noticed, however, and I think patients need to also be very aware, that you can't expect the same efficiency, the short wait times, like you have in private versus what you have in public. In public, our volume and our numbers are much bigger.
Obviously.
So, and I think that's where the bit of a miscommunication, a bit of the alignment of your expectations need to be put. And I think a lot of my patients are pleasantly surprised. And more, like you said, that the public service is doing a great job. With the many limitations that are everywhere in the world. We are doing a great job.
And all the medications and so on are available in the public.
Absolutely everything. So there are some medications
that might be a fear of people.
I think I've heard a lot of.
But you are a man practicing in the system. The medications are available.
Yeah, it is. Right. It is.
We're going to take a short break, Doc, and then when we come back, we'll further discussion a little bit more about your role in particular with cancer patients.
Absolutely.
All right, guys. So my name is Dr. Roopnarine. We're here with Dr. Visham Bhagaloo, and we're discussing cancer. What happens after diagnosis is an important part to elucidate. It's an important topic to elucidate the path afterwards. And I would like to invite you from now, I'd like to formally invite you to send in your questions and your comments, join in the discussion. It's not an easy discussion, but many of you are at home looking after family members who have cancer. Many of you might be caregivers or medical professionals. And many of you just want to be there to support someone, a colleague, a work colleague, a family member. Please send in your questions, send in your comments. It's a perfect opportunity tonight to get your questions answered and to get the proper information, all right? So we'll see you back in one moment.
Hi everyone, I'm Stacy from Stacy's Kitchen. Check out our new episodes, Season 3 of Stacy's Kitchen at our new time, 5:30 p.m. on Mondays and Wednesdays, right here on ACTN The Voice. I will be whipping you up some flavorful and appetizing dishes. as they say, good food makes a good mood. So guys, stay tuned for this culinary explosion right here on Stacy's Kitchen.
Welcome to the Chattak's Kitchen, where it's tastier and spicier. For even more taste, cook with Chattak's Amchar Masala, saffron, ground jeera, and black pepper. Mix in Chattak's mild, spicy or Madras curry. Get a burst of excitement with a mango amchar, pomsade and mango kuchila, lime and pepper chunks, West Indian hot sauce, and lime pepper sauce. Plus, Chattak's tamarind and mango chutneys are perfect with palori and sahina. So make your kitchen a Chattak kitchen. Chattak's fruit products, bringing good taste to life.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're discussing oncology, cancer care. We're here with Dr. Visham Bhagaloo. Start sending in your questions, guys, and we'll address them in the second segment, all right? So, Doc, in terms of your role in particular, right, what exactly is a clinical oncologist? And if you could just explain the difference between a clinical oncologist and a clinical
Radiation oncologist.
Radiation oncologist.
Absolutely. So there are different interpretations of our roles in different areas. So
yes.
In the UK, there's unified roles. In the US, it's very specific.
Yeah.
So in the US, a lot of times you have a radiation oncologist, and as the name suggests, they do radiation.
Correct.
You have a medical oncologist. They look after patients in terms of chemotherapies, immunotherapies, and then you have this unique group that was created, which is a clinical oncologist.
Yeah.
So we have been trained in everything.
Yes.
So we do radiation as well as chemotherapy.
Okay.
So that's a major difference. In Trinidad, there's a combination of both.
Okay.
Yeah.
Right. So can I ask you, why would a patient need chemotherapy, and why would a patient need chemotherapy and radiotherapy? What is it? On what basis is the decision made?
Yeah.
And also, what is chemotherapy?
Right. So the reasons for chemotherapy and radiotherapy, simply put, if your risk of disease recurrence or that disease coming back is highest locally, as in breast cancer, or if it's the entire body, then chemotherapy is if the risk of the disease spreading is the highest, and if it's local, it's radiation. So think about it. Radiation to breast will deal with this area here alone, whereas chemotherapy will deal with your entire body.
Okay.
And those factors are based on that pathology report that we get after the surgeon takes out the tumor.
Okay. A common notion and a common complaint is that a lot of patients say that chemotherapy, a lot say it, that chemotherapy is rough, that they feel sick on chemotherapy. Some people say that. Some people get through chemotherapy fine, no problems. Why is that? Why the variance in whether somebody could tolerate it, and why does chemotherapy make someone feel sick?
So chemotherapy, it's a drug that is placed in an intravenous access that attacks or kills cells that divide rapidly.
Right.
Cancer cells, generally speaking, divide rapidly, but these treatment, they are not specific or they are not targeted. So any cell in your body that divides quickly will be targeted by chemotherapy.
Right.
So if you have cancer cells, they will be killed, but they also target every cell that divides quickly. That includes your hair, your gut, that's why you get the nausea, the vomiting, your entire gut from your mouth straight down to the bum. So that will give you diarrhea, nausea, vomiting. Your blood.
Because those cells turn over rapidly.
Correct. The half-life or the doubling time of these cells is very, very short. And because chemotherapy attacks or addresses cells that divide rapidly, they are not specific.
Right.
With the newer onset of immunotherapy,
Yeah.
immunotherapy has revolutionized what we do.
Yeah.
Now, they are very targeted. And
What is immunotherapy?
so immunotherapy is where you use your body's immune system
Yeah.
to kill cancer.
So is that like a modern day version or improvement of chemotherapy?
So that's the assumption, but like with
sounds like
every,
that when you describe it.
absolutely, but
Yeah.
with everything,
Yeah.
there's a whole different a set of
Class
complications,
and
it's complications. So
Right.
long ago, we would talk about hair loss,
Yeah.
nausea, vomiting.
Yes.
Now we talk about inflammation of the thyroid, inflammation of the gut, inflammation of everything.
Right.
So yes, it's different,
Yeah.
but it's still
Yeah.
it's complicated. It's definitely different but complicated.
So why do persons lose their hair on chemotherapy?
So, like I said, the hair follicles, they
Yeah.
grow so rapidly
Yeah.
that they are one of the first sets of cells to be affected by chemotherapy.
Right.
So, I have a standard statement in all of my patients. I tell them, I understand.
Yeah.
Understand is probably a strong word. I am aware that it will fall,
Yeah.
but take my little opinion, it will
Yeah.
be the best hair you ever get after. It will curl if you want it to curl, it will be straight if
Start
you want
over.
it. Absolutely. And it always grows back.
Yeah.
That has been the hardest side effect we've had to deal with. There's a lot of literature now about...
Is that what patients complain about the most?
So for women, yes.
Okay.
With breast cancer, even gynae, ovarian cancers,
Yeah.
uterine cancers, Trinidad is not there yet, whereby women can rock a ball head bravely
Yeah.
in society and not
Yeah.
be judged.
Yeah.
We are getting there.
Yeah.
We are more accepting,
Yeah.
and I think it's culturally,
Right.
it's that
Yeah, yeah.
fear of that judgment.
Yeah, and I mean, I suppose in Trinidad, too, like women, the long hair, it's a sort of...
It's
It's
absolutely
tied to
to being a woman as
to
well.
being a woman as well. It's hard
And
to lose your hair.
that's been a big part of what our battles are. And now we have wig stores, and
Yes.
even in the public system,
Yeah.
we have that initiative where we're trying to help with wigs for our patients who can't afford them.
Yeah. So it means possible side effects is the hair loss, gastric symptoms,
Right.
and weakness, I suppose.
Correct.
And that's just the chemotherapy doing it. That's just the side effect of it doing its job.
Absolutely. But you made a relevant point. What I tell my patient, everybody's different. What I have realized, and what is a common complication, a common statement is, Doc, I hear from a neighbor that will get me sick.
Yeah.
So the next question I ask is, what chemo did your neighbor get? I don't know.
I suppose it might be common that a patient might come to you, Dr. Bhagaloo, in the ward where they're getting their chemotherapy and say, Doc, I can't take this no more. I can't handle this weakness and feeling sick. It's feeling worse than the cancer. What do you tell them?
So that's very common. My conversation goes on a few points.
Yeah.
It's going to be like, one, there are different ways we can adjust each, and we can address each of your complaints. So if you have nausea and vomiting, we can add extra medication.
Yeah.
If you feel tired or fatigued, we can reduce the dose of the drug.
Yeah.
If you have other side effects, we deal with them one at a time.
Yeah.
And the biggest help is usually dose reduction. And a lot of our patients are able to tolerate the drugs better. What I have noticed is our guidelines are based on an international population.
Yeah.
Caucasians, Europeans, and their fat to muscle ratio is very different. So I have personally taken an interest that Trinis have a bit more toxicity because our fat to muscle is a little bit more.
I mean, you have more fat than muscle.
Correct is right. And unfortunately, the metabolism of the drug changes.
No, that's a very good point.
And I've noticed it
Yeah.
in patients who are on the chubbier side.
Yeah.
That's a common, they tolerate treatment a little bit harder, and it's harder for them to tolerate treatment.
All right. Describe to our audience, right? So you've spoken to a patient, they need to have chemotherapy. Tell them what happens. Where do they go? How long does it take?
Right.
What is the course of chemotherapy? Is there any bloods that need to be taken? When does it end?
Right.
What happens? Because sometimes the fear of the unknown. right? We all say you had to go for chemotherapy. Nobody know where they have to go. Nobody going to know how long it's going to take when you first start.
Correct.
When you first start.
Correct.
How long it's going to take, or if it's going to hurt, if it's not going to hurt. What if they could leave? Were they going to feel sick right away? If they have to take any medications? And some of our GP colleagues need to hear this as well, so we can advise our patients who are scared to go for chemotherapy.
Absolutely.
Can you explain that to us?
Right. So currently in Trinidad and Tobago.
Where do I go for chemotherapy?
Right. So in Trinidad and Tobago, there are 4 major sites. So there's Tobago.
Yes.
That's the hospital in Tobago. They do it. There's Sangre Grande in Trinidad and Tobago. Right. There's the National Radiotherapy, which is the St. James Medical Sciences Complex.
Yes.
And there's San Fernando General Hospital.
Right. So those are the
public areas where chemotherapy is afforded.
All right. I'm not going to ask you to name them, but they are private institutions where you can get chemotherapy.
Absolutely.
Okay.
And those exist as well.
All right.
Yeah?
Right.
So what you do when you get referred to the oncology department, you'll get a referral either from the surgeon or from whoever.
Yeah.
You come in.
Yeah.
We will assess your case, determine what you need.
Yeah.
So if you need chemotherapy, we will engage. So we will say, sir, ma'am, this is what your diagnosis is.
Yeah.
This is what we suggest.
Yeah.
In my institution, we print literature
Yeah.
on every drug that we expect you to take, and we hand it to you in your hand.
Right.
Every time you need to have chemotherapy, you also need to have blood investigations done.
Okay.
In our institution and in the institutions that are in the public setting, it's done in that center.
Right.
So you don't have to do it anywhere else.
Right.
Typically, they will do a complete blood count.
Yeah.
That is to check your hemoglobin, your white blood cells, and your platelets.
Yeah.
Your kidney functions and your liver functions.
Yeah.
And each tumor has individual tumor markers, which can be also used.
Right.
After you have that, what we do is we take your height and your weight, and that's how we calculate your dose of chemotherapy. So always remember, your chemo dose, your chemo drugs are unique for you, your height, your weight, and your cancer.
Okay, it's specific.
Absolutely. We are pinpoint on what we have to do. When you get your chemotherapy, you will come into either of the institutions. They will put up an IV access in your hand. We will go through and get consent. So this would all be done knowing that your investigations before are all clear and it's safe to administer medication to you.
All right. And when you go into the oncology ward to have your chemotherapy,
right?
Roughly, like, how many patients are around you?
So in some of the institutions, it's separate. It's not actually a ward.
Right.
So we call ours in San Fernando, it's called the oncology suite. In National Radiotherapy Center, it's an oncology suite as well. So you come in, the treatment is administered on recliners rather than beds. Typically, in some of the institutions in San Fernando, you can go between, I would say, 15 to 25 chemotherapy patients a day.
Right.
In National Radiotherapy Center, they can go up to 40 plus. I stand to be corrected with numbers. And in Sangre Grande, 10 to 15 as well.
Right. And how long does it take to receive this medication?
Correct. So each drug is unique. Each drug has specific times for which it must be administered over. For instance, breast cancer, you would talk about adriamycin and cyclophosphamide. They have 15 to 30 minutes each. You have longer drugs like paclitaxel, which should go over 3 hours. And then you have some drugs that need to be infused over 24 hours. And those patients are admitted to the wards.
Okay. And how often does a patient need to come back for the chemotherapy?
Every drug is unique again, but the typical way we do it is every 3 weeks. Sometimes it's every 2. But when you leave either institution, it's clearly identified on a card. This is when you come back.
All right. And what happens if when someone is leaving, obviously the anticipation is they might get a little bit sick.
Right.
How do you treat for that possible problem that's going to flare up at home?
Correct. So what we've done is every drug we treat as worst case scenario. So you are given medications as worst case.
Right.
So you're given medication to stop the nausea and vomiting if it happens. Certain protocols or certain drugs have a high chance of vomiting, and they are given medications to treat that.
Right.
What I can say is there's a new initiative at Southwest Regional Health Authority where there's a number given to patients and they have access to doctors up until 10 p.m.
Right.
So
very good.
Absolutely. And it's something that the institution is very proud of.
So if someone is unwell,
correct,
they could call this number.
Correct.
And one of the public health doctors would answer it to give them advice.
Correct. So what we're trying to do is we're trying to limit the interaction between an ill oncology patient and the many infections that emergency departments may or may not have.
Exactly.
But I think what we've learned and what we are trying to mimic is international systems, whereby telephonic support is always available to patients. And I think that is what SWRHA has been initiating, and it's been bearing fruit.
Okay. That's a very good answer. That paints a picture of what happens. And obviously a very important telephone support to patients who might not know they have that telephone support.
Absolutely.
Do you have the number offhand that the patients could call if they aren't feeling on?
Absolutely. So just a few disclaimers on that.
Yeah,
you must be a patient of the oncology department in SWRHA, and the number is 225-1845.
Okay. That's the oncology part of it. What is radiotherapy?
Right. So radiation or radiotherapy is X-ray beams that are shone on an area of the body to minimize the possibility of the cancer coming back.
Yeah.
So we have these fancy machines, they're called linear accelerators.
Yeah.
How radiation works is you will do a CT scan first on a special CT scanning machine.
Yeah.
Then that image will be taken by a radiation or clinical oncologist like myself.
Yeah.
We sit and we draw where the cancer is likely to come back, where we want that dose, and it's precision. The National Radiotherapy Center, the Cancer Clinic in St. James, they have gotten state-of-the-art radiation machines. It's quite impressive.
Very focused.
Absolutely, and it's going to change the way radiation is done in the public system, and it's already bearing fruit. Lots of
radiation stops the cancer from growing?
So generally speaking, we can use radiation in two forms. We can use radiation to shrink a tumor to make it easier for a surgeon. So if you have somebody who has rectal cancer, what they will tell you is they didn't cut. We give chemo first, radiation second, and we wait 8 to 12 weeks, and then the surgeon takes it out. So in that case, it's used to shrink.
Easier surgery?
Correct. Theoretically, some of the surgeons will argue with me, and they will say, doc, you know, it's sticky inside there, that's not easier. And I'll be like, I understand, but the theory now for rectal cancers, that is the approach. All the chemo and radiation first, surgery second. With breast cancer, we use it to get rid of microscopic disease in the chest and under the axilla, where recurrence can happen locally.
So we have a patient going through all of these things. You've explained it fantastically. And then the question that a family member would ask is, doctor, is my mom or my dad getting better? Is their cancer being cured? How do you answer that question?
So that's very complicated as well. And we've had lots of...
Because mommy went through 10 chemotherapy sessions, and mommy had 3 radiotherapy sessions.
Right.
Are we winning?
Right. So what is important is where we started. So one of the most important aspects of our first conversation with an oncologist or an oncology doctor is to determine what stage you are and what the intentions are. So you need to leave that consult knowing, one, what is my stage, stage 1, 2, 3, or 4, and what is the intention of the treatment? Is it to cure you, or is it to control, or is it to palliate?
I understand.
Very important. And a lot of patients in the hullabaloo, in the emotional aspect, they leave the consult not knowing those answers. And that is important. So for instance, a patient who is curative in intent, we only image at the end of treatment because there's nothing. We know there's no disease, so the literature tells me I need to give 4 cycles of this chemo, 4 cycles of that chemo, and 25 days of radiation, and when that is done, I will then scan. But theoretically, from the literature, from the information, that cancer is not supposed to come back.
All right. So I understand that to answer the question, you have to know what you started off with and what is the goal of the treatment.
Correct.
All right, but what diagnostic tools do you use to help you know whether a cancer is regressing or not?
Right.
So let's say after your chemotherapy,
Absolutely. So the most important tools that we use is any form of imaging.
Right.
So something as simple. So a patient who has a stage 4 cancer, who has fluid in the lungs, we, because of resource limitations, we've adapted. I can use an X-ray for a large pleural effusion, do an X-ray at a simple cost to the regional health authorities, and I can see the fluid level levels getting less and less.
I understand.
That's a simple way.
Yeah.
If somebody has ascites, I can do an ultrasound. Ascites is fluid in that tummy.
Yeah.
We can do an ultrasound and see the volume of
Regressing.
fluid regressing. But the go-to are typically CT scans and MRI scans.
Okay.
And the one thing you would hear about, everybody speaks about now, is PET CTs.
Yeah.
And that is the new kid on the block, in Trinidad, not necessarily abroad. And that gives us a lot of promise,
Right.
because it helps us quite a lot.
All right, so Doc, we have to take another break now. So guys, we're here with Dr. Bhagaloo. We're discussing cancer care. Please send in your questions and comments. We're going to answer them in this section of the program, and we'll see you back in one moment.
And when God sends a word, it serves a purpose. It serves a purpose because you serve a purpose. When you hear no, I want you to think next. So if God didn't let me do that, next. Jesus didn't call them to leave their boats. He called them to push out a little. It's a little decision so that I would rely on the grace of God. It's the blessing of both.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. I have Dr. Visham Bhagaloo with me. Please join in the conversation. Send us your comments, if not your questions, and let us know what you are thinking. So, Visham, just before you went off there, I was asking you, how do we follow up to know someone is getting better or not? You said that there's simple ways to check certain things, but then you also mentioned that there's more complex radiology that they could use, and you mentioned a PET CT scan, a PET scan. Explain what that is.
So PET CTs have revolutionized the way we manage cancer.
Okay.
So what PET CT scans do simply is, in addition to, when you do a CT scan, you see geography, you see location. So you see the lung, you see the liver, you see the spleen. There can be masses, there can be no masses. These masses can represent a cancerous growth, and they can represent a benign growth, a benign meaning a non-cancerous growth. Before, there was absolutely no way for us to tell. We would do these imaging, we would see these masses and have no idea what they are, so our next step will be biopsy. What a PET CT scan does is it actually gives us information about functionality. What that means is, if you have cells that are dividing rapidly, it lights up like a Christmas tree. So they have changed a lot of the ways we manage a lot of cancers, head and neck cancers, cervical cancers, many cancers. Prostate cancer is such a big burden in Trinidad because there's a lot of studies that show Indo and Afro-Caribbean men are at a higher risk. And they've also introduced PSMA PET scans in Trinidad. And these are making our job a lot easier in decision making, because there's a lot of grayness in oncology. If you see a lesion, you can't tell what it is. You can't easily biopsy it. What are we to do? Now, these PSMA PET scans or the FDG PET, they're all changing how we are able to interpret information, and most importantly, give our patients the best quality of care.
So you have the patient after they finish radiotherapy and chemotherapy. What sort of, let's say someone has sort of the chemotherapy has worked well, and they've gone into I suppose now is a good time for you to explain the difference between remission and cure.
Right.
And if you could tell us what sort of follow-up that those patients need, how often they need to come in to see you or into to see the other doctors in your service.
Absolutely.
And what is done at each visit for them.
Right. So remission and cure is two very powerful words, because that is your patient asks you that every single time. Doc, can I say I'm cured now?
Yeah.
So cure simply means that there's no evidence of disease anywhere.
Yeah.
And that, to me, is such a difficult way to tell somebody. I've seen patients with early disease who've had recurrence in a year or two. I've seen patients who everything on that pathology report tells me it should come back, and it's never come back.
Yeah.
So there's a lot beyond genetics that we still don't know.
Yeah.
So that is my thing. Remission means that the cancer cannot be detected. And we use that a lot in hematological malignancies.
Yeah.
So, you start the treatment, your white blood cells were in the hundreds, now they're back to normal.
Yeah.
You do the bone marrow test, there's no cells. So that is what remission. Remission means there's no current evidence of cancer. You can go into short-term remission or long-term remission.
All right.
And cure simply means there's no evidence of disease radiologically, clinically, or biochemically.
Okay.
Yeah? Okay. No. Any patient and every patient who has a diagnosis of cancer is followed up based on international guidelines.
Yeah.
So if you have a CA colon or if you have a breast cancer, you are seen every 3 to 4 months.
Yeah.
When you come in, if you have a particular tumor marker that your cancer expresses, you will do a blood test before.
Yeah.
If you're a breast cancer patient, we do an examination.
Yeah.
We ensure if you are taking hormonal medications that you are tolerating it well.
Yeah.
And if you're tolerating it well, we ensure that that script is filled. So every single patient has a standard algorithm as per international guidelines of how often, what examination, what blood investigation, what imaging, and what external intervention is needed.
Okay. We have a few questions coming in. Josh, I think now would be an appropriate time to gauge what's happening out there. First question, what causes cancer?
So that we can talk about that for hours.
Let's give us a brief answer.
So generally speaking, cancer is caused by cells that do not respect the process.
Yes.
In science, we are told that cells go through a cell cycle. They grow. When they get older, they die.
Yes.
In cancer, that mechanism of switching off or sending a cell into old age is no longer there, and these cells just keep going. Because they are a little bit on the older side, errors occur. And now they just keep growing and growing and growing. They respect nothing, and that's why they become problems.
Cancers.
Correct.
Next question there, Josh. Does smoking cause
Absolutely. Sorry.
Yeah, go ahead. I think that's common information, common knowledge.
No, I'll tell you why I'm laughing. Is because I love that somebody actually engaged that question. Because
why is that?
I'm not sure why Trinidadians believe. I mean, this is on every cigarette pack. This is everywhere you go. You see signage about smoking.
Yeah.
I think what I want to hammer home is that smoking can cause lung cancer, head and neck cancer, every single cancer. I can find a reason that smoking can cause it.
Smoking cigarettes.
Yeah.
But let me ask you something about vaping. I see a lot of people do vaping.
It is associated with cancer as well.
It is as well.
It is, yeah, it is. There's recent literature that was published that said the assumption was that it would be better, but it isn't.
Right, so those people are wrong.
Absolutely.
We think that is...
Absolutely. So it's a combination of what you're vaping.
Yes.
So it's the same principle.
Yeah.
But vaping is not good. The way to stop it, the way you need to stop is stop smoking, please. That is the way out. Right. People try to cut down.
Yeah.
But yeah.
How about smoking marijuana? Same risk as smoking cigarettes for cancer?
That's another complicated question. No. There are risks.
Yeah.
The issues with marijuana in a local population is what is added to marijuana.
Right.
That is where it becomes complicated. So if you look at the literature and you talk to anybody, everybody's talking about CBD oil.
Yeah.
And CBD is extracted from marijuana.
Yes.
But the issue with marijuana is there's so many other components that we don't fully understand the side effect profile.
Okay.
So I have patients who will come into me and who have problems in terms of pain, who have problems in terms of this. And when I explain to them what CBD oil is, they're like, if I'm okay. And I'm like, no, this is well documented in our literature, and the use of CBD for nausea and vomiting associated pain associated with cancer, and many, many things. It's well documented and well supported, and I have no hesitation in using it in the right situations.
It's the CBD oil, is it?
Correct.
So what is it? Is this literally an oil?
Yeah. So what? So I don't.
It's the same thing that you get from smoking marijuana.
So they've
extracted it.
Correct, and they've tried to target the beneficial aspects of marijuana and put it in an oil. So what patients do is they add it to their liquids when they drink food, when they eat, and it helps quite a lot.
Okay, good answer, Doctor.
Yeah,
good answer. Josh, any other questions? Can my hair grow back after treatment?
Yeah, absolutely. So it always does.
Yeah.
Generally speaking, the younger you are, the quicker it recovers, and I think that's with every single side effect. I think younger patients tolerate. I have a very young patient that I'm treating currently, and she experiences no toxicity. Her hair has fallen.
Okay.
But at the end of the day, I expected that. That's the other one. But younger patients are so resilient.
Yeah.
And they usually tolerate chemotherapy very well.
And is it that hair from the whole body falls?
Everything. Hair, eyebrows, eyelashes. Beard, everything. Okay. Yeah? Okay. But not every drug. And I think that is very important. And I think if your fear is hair loss and what side effects are your fear, please ensure that your cancer treatment, what their side effects are. That's why at my institution we have insisted on providing literature, typed literature, so you know exactly what you are expected or what the studies and the literature suggests will be your side effects. Yeah.
Cancer oncology medication is very expensive, isn't it, worldwide?
Absolutely.
Yeah. Now, I mean, how much, I'm not asking you for private fees, but like, how much do these medications cost the public health sector, for example, to treat a patient with cancer?
A lot.
Because we have a lot of conditions and medical conditions in the country, chronic conditions as well. And the big discussion worldwide is that people need to know that this is the cost per patient to treat in a public health facility. That's, in some countries, I think they actually publish it, how much it costs to treat a patient. How much does it cost? Not that the person with cancer is responsible for their condition necessarily, because it just happens sometimes.
Absolutely.
But how much does it cost to treat a patient with cancer? So because this could be used for information to understand where we could allocate resources towards screening and prevention of cancers, and where we should have screening programs.
So there's no doubt that the cost. One of my colleagues has done a lot of research on the cost to screen a cervical cancer patient versus the cost to treat a cervical cancer patient, and it's absolutely there's no question about it. A pap smear plus a HPV co-testing is about 1,000, if so much, and in the public system it's 100 times. It's cheaper because in the public system the cost that the governments pay is always less. All right, so that's generally how it goes. Each drug is unique. I would say on average we can talk about a breast cancer patient. But if you want to compare like the cost that they would pay in private it's hard for me to tell you the cost of government, but I'll give you a general idea. So I would say it's close to about $250,000 to 300,000 TT to do chemotherapy, radiation, all the meds, and to start the hormonal medications.
That's fine. Just to have an idea of the cost of these medications.
It is not. I've been at meetings and I was told on multiple occasions that oncology takes
a lot of money.
Out of the general budget for meds for the rest of the conditions.
All right, so I've just in my ear there saying we have about 4 more questions and about 5 more minutes left.
Okay.
So we'll move on. With so many advances, why isn't there more progress? Good question. Is it true that there has not been progress? I would debate that.
Yeah, I would debate that as well.
I mean, they're making great headways with head and neck cancers. I think in England they recently published that they're close to actually being able to cure these diseases if gotten early.
So what I would say is that, like everything in Trinidad, we usually hear the bad. The success stories are very quiet, and we don't hear them.
No, but I mean, I get that point too, man, because we lose people.
Absolutely.
Tonight, myself and yourself lost one.
Absolutely.
And we did everything we could.
Absolutely.
You know that.
Yeah.
But it just happens.
No, so what our advancements have been, our advancements have been very, very, in terms of treatment, in terms of chemo and radiotherapy, we have gotten there. We are getting better, and we are evolving, and we are getting better.
I think so.
But late and advanced stage diseases, the gold standard around the world, in the US, the UK, and Canada, those drugs are not available locally.
Yeah.
So if you want to compare us to an international setting, we are back on those drugs.
Yeah.
While that is our aim for the future, there's a lot to do with what we have to get us better and gradually increase. In the US, like I always tell my patients, that is completely funded by insurance. So people have to always remember that. Here is public.
Yeah. I suppose the answer to that question is obviously we haven't won the war. And we'll never win the war.
Yeah, we would.
But you'll never win. Have you won the war on drugs?
No.
No. But we have made a great progress, and we're fighting, and we're trying our very best. And yes, we do have people that still pass away from cancer.
But we are getting better.
We're getting better.
Absolutely.
We're getting better. Next question there, Josh. Can stage 3 ovarian cancer be cured? And can it be caused by secondhand smoke? Good question.
So yes, stage 3 ovarian cancer is cured. And can it be caused by smoking? Now you're going to make me look like a fool, because I said before nearly everything. With ovarian cancer, very unlikely.
Unlikely.
Ovarian cancer is one of those cancers that has a lot of genetic predisposition, simply meaning it's a lot of genes that you inherit. And in that situation, if your relatives are known, if your relatives have this disease, that is usually the biggest factor.
Next question there, Josh. Should everyone get a second opinion? That's
a lovely question.
Sometimes when I deal with patients with cancers, I pick up the phone this morning, I call you. I said, doctor, am I doing everything I should do? Am I missing anything? And am I doing right by the patient? And I think that's a question all doctors in this field ask themselves, and sometimes we get second opinions from others. We ask ourselves that question. And it's not easy dealing with cancer patients. We ask ourselves that question when we see our patients getting sick. And we ask our colleagues as well to look over our back and to make sure that we're doing the right thing. And a lot of the times, yes, we always ask people to get a second opinion. We're not embarrassed by that. At the end of the day, we want to make sure we do the right thing.
And I think that's a sign of maturity. And I think any physician who's worth their while will always ask. In the public system, what I can guarantee you, that is a multidisciplinary team. So it's always a group of people making a decision.
There tonight, that it's a group of people who make
it's always a group.
And for us who practice in any community as well, we always reach out to people like himself. I mean, that's how I met Dr. Bhagaloo, because dealing with patients and calling them and asking them, am I doing the right thing? Are we doing the right thing? What could you do? Give me some feedback. And that's how we meet each other. So yes, second opinions are important, and we do talk to each other. We do talk to our colleagues about these special cases. Next question there, Josh. When is the part 2 of this program? Soon. I think it's an important topic. We're trying our best. We have a lot more to discuss here, and we ran out of time more or less. But it's all up to Dr. Bhagaloo. When you have, are you willing to come on again, Doc?
I will make myself available.
Yeah. Josh, we have any more questions? Do you right on time? All right, guys. So we're going to wrap it up now. Doesn't make sense taking any more. We've answered what's on the table.
Absolutely.
Doc, thanks for coming out. Thanks for coming on this show. I know I've been talking to you intermittently over the last few months. I know you have a busy schedule. I want to say one thing, though. I thought you did a very good job tonight.
Thank you.
A lot of these questions I gave you tonight and discussed with you off the cuff. We had no sort of significant preparation, but you described to the population what happens in the public sector.
Absolutely.
And it certainly took them on a journey. We haven't discussed everything, but we certainly took them on a journey to a certain point where they could feel a little bit more comfortable if they receive a diagnosis of cancer.
Absolutely.
I think what really came out, though, I think people could be confident that people like yourself are in the public health sector, and that you're true professionals, and that the facilities is available, and your support staff like the nurses, they really do a good job.
Absolutely.
And that's the feedback I get from my patients as well.
Absolutely.
And also, I just want to wish thank you as well for always being there for us in GP practice, GP land. Some of us are practicing out there with the community, and also always being willing to lend your advice and expertise on the topic to us.
Absolutely. It's my pleasure.
All right. So great having you on.
Thank you very much for having me.
All right, guys. So thanks to Dr. Bhagaloo again, and thanks to you out there for reaching out to us and sending in your questions. questions and comments. I know they have a lot more questions coming in, and we will do a part 2 of this program. All right, guys, so to all our cancer patients out there, keep well, keep safe. We hope you feel better, and we hope you continue your treatment and you get better. To everyone else, thank you for joining us tonight. Have a pleasant evening. God bless you all, and we'll see you again next week. Take care now, guys.